Hello, and welcome to decision making surrounding surgical and ablative procedures to treat facial pain. I'm Melissa Bombeck, the FPA's CEO, and I'm happy to welcome Dr. Richard Zimmerman, Professor of Neurosurgery at Mayo Clinic and member of the FPA's Medical Advisory Board. Dr. Zimmerman has focused his patient-centered clinical practice on surgical options to treat severe facial pain and microsurgical treatment of hemifacial spasm. Thank you for joining us, Dr. Zimmerman. Before we get started, I'll ask that attendees submit questions using the Q&A feature on your screen. We'll get to as many as we can after the talk. And now I'll turn it over to Dr. Zimmerman.
Well, good morning or good afternoon, depending upon where you are. Thank you, Ms. Bombeck, and I want to appreciate the Board of Directors for inviting me to participate in the conference, which is such an outstanding opportunity to provide patients information that they need. What I'd like to talk about this morning, or again this afternoon for you, is about decision-making for treatment options and treatments available for your trigeminal neuralgia. And I thought that the best way to do that would be to cover some basics. I work with a very big team of a neurosurgical department that is focused on assisting me with the facial pain management, a bunch of neurologists that work with facial pain and headache, a radiation oncologist, neuro-ophthalmologists, interventional neuroradiologists. It's a big enterprise that really wants to focus on helping patients in various formats. I have several disclosures. I do work with some medical advisory boards as the MAB for the Facial Pain Association and others as well. What I thought I'd do, though, is not give you an individual's perspective, my outcomes of how to decide what to do. But I went back into the literature and looked for very relevant large reviews. Now, this review by Dr. Rapasarda and colleagues looks at exactly what this session's about: out comparison for drug-resistant trigeminal neuralgia using surgical treatments. Now, an umbrella review is the highest level of review that you can do. It takes meta-analysis, which is an analysis of multiple analyses, and systemic reviews, and then combines them to give you a meta-analysis, so the super high level, looking at many, many studies, and what do they really tell us about the outcomes from surgical treatments. Now, they looked at 10 meta-analyses or systematic reviews. That led to a review of over 187 studies comparing the outcomes from surgical options. And I think that would be a great article to use to substantiate what the literature says, not give you an individual's perspective, because obviously that would have a lot of bias. And then the second article I wanted to present and discuss is an article by one of our previous medical advisory board members, Dr. Zakshevska. And this is the treatment outcomes in trigeminal neuralgia, a systematic review of domains, dimensions, and measures. What that means is that what were the criteria, what were the types of results that were actually looked at? So is it just pain, pain relief, patient satisfaction, and a whole bunch of other issues like quality of life, psychosocial status, all the other factors that could be used to measure the outcome when you treat facial pain, either with medicine in this case or with surgery. So I'm just going to focus on a lot of the data. And in that study, there was a huge number of articles, and we'll talk about that in a second. So that first article that I referenced, Rapasarda, that was a really outstanding article because it uses a nice methodology to look at these surgical procedures for trigeminal neuralgia. One category that they broke it up is called etiological. And that means they're looking at the etiology of facial pain where its vascular compression has been identified. And clearly, when you want to treat the cause of your facial pain, when it's felt to be vascular compression, they go down the pathway of what are the MVD outcomes. Now, in cases where you're not treating an etiology, idiopathic trigeminal neuralgia, or you don't want to have surgery, they consider the other options what they call palliative or really ablative, which means you're destroying normal neurologic tissue. And we'll talk about this as well. What is the difference between a central ablative procedure and a peripheral ablative procedure relative to the trigeminal nerve? The central ones are the ones you're most familiar with, that most neurosurgeons are familiar with. Percutaneous balloon compression rhizotomy, percutaneous radiofrequency rhizotomy, percutaneous glycerol injection rhizotomy, and then stereotactic radiosurgery or gamma knife surgery. Obviously, the balloon compression is a technique that causes mechanical injury to the nerve. Radiofrequency lesions cause thermal injury to the nerve. Glycerol causes a chemical injury to the nerve. And then SRS, so stereotactic radiosurgery, and gamma knife surgery both use radiation injury to the nerve to desensitize or damage the nerve to stop the pathological occurrence of trigeminal neuralgia form pain. Now, there are peripheral ways to also damage some of the nerves. We won't talk about those today in the limited amount of time that we have, but I will go through some of these to give you an idea of how to make a decision. Now, MVD is the most invasive, and microvascular decompression, as you know, is an incision that's required to be made behind the ear. We have to remove a small amount of bone and then go and expose the brain, go around the surface of the brain to get to the trigeminal nerve and mobilize any vascular compression against the nerve. In distinction, these percutaneous procedures, whether it be balloon compression, radiofrequency rhizotomy, or radiofrequency lesioning and glycerol rhizotomy, those require deep sedation, because when you do these, when you introduce a needle through the trigeminal nerve, it is very uncomfortable, short of saying it's really painful. So deep sedation and sometimes even general anesthesia can be necessary. So while it's not as invasive as microvascular decompression or craniotomy, as we call it, it's still fairly invasive and painful. Whereas the non-invasive options for stereotactic radiosurgery and gamma knife really may or may not need sedation, depending upon how calm you are during the procedure. And we'll discuss some of those as well. Now, the issue with these, as opposed to the other treatments, either here or here, is that the outcome from radiosurgery, from radiation treatments, is typically delayed. So if you're having an acute attack of trigeminal pain, you don't want to choose this as an optimal avenue of relief, because you may not get relief until sometimes weeks down the road. But on the other hand, this is non-invasive. So in terms of risk of a surgical or interventional procedure, it has much less risk. That's not to say that radiation has no risk. It certainly does have risk, as any injury to the nerve does. But there's none of these surgical risks like infection, CSF leak, or bleeding that can occur with either of these two. Obviously, if you need general anesthesia and your medical condition or health is limited or has compromised, bad heart, other problems where you don't want to have anesthesia, these provide opportunities or alternatives. Now, we'll take in order those three. MVD, obviously, when you have the brainstem, the trigeminal nerve, and a blood vessel loop pushing on the nerve, the goal of MVD surgery is to remove that compression. So you can see the impact of what compression can cause, and the advantages in restoring a normal nerve to its ideal state. Now, there are many ways to do this, but the goal, again, is freeing up any vascular contact of significance, because there are many vessels that innervate the trigeminal nerve that are normal, that supply the blood flow to the nerve. But major compressive vessels, whether it be arteries or veins, need to be moved and then kept out of the way by a variety of means, in this case, using glue to keep the blood vessel away. Again, this is a repetitive feature. Vascular compression is felt to be the most common cause and the only etiological cause of mechanical compression of the trigeminal nerve. We also do know that multiple sclerosis is one of the causes that can happen with or without vascular compression. When you have multiple sclerosis, we also have patients that respond to those other ablative procedures. So this is what I referred to before in terms of learning about the trigeminal nerve. The trigeminal nerve is called a bipolar neuron because the nerve has a structure where the cell body and the nucleus is in the mid portion of the nerve, if you will, where the peripheral branches innervate the face and the central branches take the pain and sensory information to the brain. Now, when you do a lesion out here on the distal, if you will, or far end of the nerve, these are what the peripheral procedures do. Central procedures attack the cell bodies in the ganglion, and we'll talk about the trigeminal ganglion, or when the nerves have a central process and you injure this process, that's the target of the other ablative procedures. And of course, at the root entry zone, right before the nerve enters the brainstem, that's where we look for vascular compression and how vascular decompressions are done. Now, this is a little bit of a blown up illustration of the trigeminal nerve at the Gasserian ganglion, at the trigeminal nerve ganglion. This is where those cell bodies and nuclei are. This is the nerve root coming into them. And these are the peripheral processes leaving through their respective openings in the skull called foramina. And this is the foramina valley. The percutaneous procedures that I mentioned all follow the same basic route. You want to damage the nerve by introducing typically a needle that has a nice large center through foramina valley, through the nerve, into the body of the nerve or the ganglion. And then you can do a variety of things. I'll also mention that sometimes lesions or injury to the nerve can be done on the other side. And we'll talk about that in a second. As I said before, there are multiple ways to use the percutaneous procedures. In this case, this is a superimposed lateral X-ray where the needle is actually shown here as a stylet. There's a tiny micro balloon that's inserted into the Gasserian ganglion region, into Meckel's cave. And when you inflate the balloon, it becomes opaque with contrast, but it assumes the shape of Meckel's cave. And this balloon compresses and damages the nerve by a mechanical force through the balloon compression rhizotomy technique. In a slightly different venue, if you introduce a needle, and you could introduce liquid glycerol. Glycerol is a toxic substance that can gently damage the trigeminal nerve at the level of the ganglion or anywhere along the root. And in the final fashion, if you wanted to look at radiofrequency lesioning, again, a needle with a cannula that allows an electrode to be passed through that, the electrode can then heat up or thermocoagulate, i.e. damage, some aspects of the nerve. And of course, with any of these types of rhizotomies, when you damage the nerve, you're going to reduce its sensitivity and ideally reduce the incidence of having an exacerbation of your trigeminal nerve pain. Now, how is that typically done? And I'm not sure that many of you have seen how these percutaneous procedures are done. So we need to follow, this is an X-ray of a skull model, not an actual patient, but we point out some significant landmarks. So at the skull base is an opening that's oval shaped called a foramen ovale, and that's easy to identify. And that's palpable if you reach inside the patient's mouth. When you're doing this procedure, you can find this bone called the pterygoid process, the pterygoid plate, at the base of the upper molars, at the very top of the mouth. And that you know that by feeling this, you start inserting the needle through the cheek towards this small opening. However, you have to be very aware of what's nearby with these foramina ovale. This is the foramen spinosum, or a small passageway that a blood vessel goes through. And these are openings that transmit the carotid artery. Now, sometimes there's a thin bony plate that protects the carotid here, but sometimes it's not. This is an MRI of the skull base showing, again, a little bit more graphically, the location of the foramina ovale for the trigeminal nerve, the V3 distribution. And then here's the foramen spinosum with the middle meningeal artery coming out this side and going laterally. This supplies the blood flow to the dura, the covering of the brain. But again, look at the proximity of the foramina ovale to other vascular structures that could potentially be a problem. This is a front view, what we call a coronal section, and it's very magnified. So it's a little hard, but I want to identify that opening in the bottom of the skull where the nerve V3 is coming out, and that you can see the proximity of that to Meckel's cave. This is a CSF-filled space. That's where the trigeminal ganglion is located. On this side, you have a better view of Meckel's cave, and you can see the trigeminal nerve coming out. So the needle comes up from below, enters the foramina ovale, and then enters Meckel's cave, where you can do one of the three procedures I just reviewed. Now, the challenge is that things are not always as clear as the X-ray that I showed of the skull model. This is a real patient who has osteoporosis. And I challenge you to say that you can easily find the foramina ovale on this side, even on this side. But I'll show you that with enough experience and enough good X-ray technicians, you can find the foramina ovale, and I'll go back and forth here so you can see it by yourself on this side, the non-surgical side. On this side, however, it's quite difficult to see. Now, one of the things we've done in our practice is then you have to advance the needle past the foramina ovale, which is at the skull base here, and get it into Meckel's cave so you can deliver your treatment. One of the things we've done here to localize the foramina ovale nicely in patients who do have osteoporosis is to combine a little bit of a high technology image guidance, merging skull films, CT scans, and MRIs to identify Meckel's cave and find the optimal trajectory to avoid those high-risk structures like the carotid artery. And you can see here how nicely you can target just inside the jawbone through foramen valley and into Meckel's cave. And you can see here, just inside the jawbone, directly into Meckel's cave. And again, that helps visualize the target that you're trying to achieve for those percutaneous procedures. Now, to close out the techniques that we use for rhizotomies, this is a picture of the Gamma Knife unit. This is a picture of a LINAC unit, or a stereotactic radiosurgery unit. We'll use the advertiser for putting the patient in backwards here. This is a model that's in backwards. But the bottom line is the patient's placed in a gantry or a table in both cases, and they're placed into the location where they can receive radiation treatments. In the case of the Gamma Knife unit, there's a large cobalt source inside the unit. A large amount of cobalt provides radiation. And then in this case, electricity provides, through the LINAC, the linear accelerator, the radiation that is targeted around the brain. They both work on somewhat similar principles. They both have a radial orientation of emission of radiation. This is controlled by little collimators or little tubes that can be open or closed, and they permit very fine beams of radiation to get to the target in the brain, in this case, the trigeminal nerve root. And what you notice that every little spot gets a tiny bit of radiation, except at the target zone. This is working just like a magnifying glass, sending all the radiation to a very small area that gets a high dose, while the rest of the brain gets a minimal dose. This is the LINAC, and the big difference to exemplify here is that for the Gamma Knife, you need to have a head frame placed on where it is fixed firmly to the patient's skull so the patient holds still. With the LINAC, you don't have to have a rigid frame. You're able to use this form-fitting face mask to hold the patient still during the treatment. And in the LINAC case, this arm moves about in several different arrays or radii around the patient's head, again, targeting one spot with a high dose of radiation. Now, let's get to the tough part about this story. How do we figure out what's the best treatment? And again, based on some of the patient's preferences, that's the main criteria that you choose one of these. What's your preference as a patient? But when you go through the systematic reviews and meta-analysis, certain things do come to light. In this case, they looked at the percutaneous procedures, percutaneous balloon, radiofrequency, and percutaneous glycerol, and then the stereotactic radiosurgery. And they find a few things, that radiofrequency was superior to glycerol and SRS in terms of early and late response for pain relief, but had the highest risk of complications. Percutaneous glycerol injection was superior to stereotactic radiosurgery in terms of early pain relief. This works right away. As we said before, this has a delay, but glycerol is the least effective after about 2 years. Now, you can go through all of these. You do find out when you have MVD in the comparison group with the SRS and Gamma Knife, MVD has greater both short-term and long-term freedom. MVD is superior to Gamma Knife. MVD is more effective than Gamma Knife surgery. In more meta-analysis and systemic reviews, you find, again, what do they look at? These are the percutaneous procedures: balloon compression, radiofrequency, and glycerol injection. Radiofrequency has a higher immediate pain relief as compared to glycerol, but increased risk of anesthesia and decreased risk of an eruption of herpes, herpes zoster, herpes simplex. Balloon compression had the highest risk of chewing weakness, had the highest risk of cranial nerve palsy compared to glycerol, and that between balloon compression and radiofrequency, there was no significant difference in terms of efficacy and safety outcomes. So they're kind of equivalent. This study looked at all of the above, including cryotherapy. And again, MVD comes out with the highest success rate, lowest recurrence rate, longest pain relief from a time standpoint, although it did have the highest complication rates. Balloon compression, initial pain relief is comparable, but short duration. Gamma Knife surgery, long interval for initial pain relief, higher recurrence rate, few complication rate. MVD had the lowest recurrence rate. So you can go through all these studies comparing multiple ones, but I want to point out a few things. They really recognize in this systematic review that there's really a lack of good studies to support one treatment over the other, and I'll cover that in a second. In this case, we talk about MVD had the lowest recurrence rate, but they talk about MVD and percutaneous sensory rhizotomy or partial sensory rhizotomy. This means they're stroking, combing, squeezing the nerve, pinching the nerve, cutting the nerve parallel to the fibers, called an internal neurolysis. They're doing things to the nerve that really mean they're damaging the nerve as well as doing a vascular decompression. This is no longer a pure MVD. And in this case, you will expect numbness after surgery. Again, other percutaneous procedures are reviewed: percutaneous radiofrequency, glycerol, and balloon compression compared to MVD. Radiofrequency was safe and superior to balloon compression or glycerol. with concern for pain relief and a recurrence rate. So it seemed that radiofrequency was good, but still inferior to MVD. MVD appears superior. So looking at all that, I think, again, with the bias of being this is a surgical group looking at these outcomes, that microvascular decompression, the ideal goal is no loss of function, i.e. no numbness. That's not what we typically expect if you add something like combing, stroking, internal neurolysis to your MVD. The percutaneous procedures are, less invasive. They need less anesthesia. The balloon compression radiofrequency seem to be relatively equivalent, probably a little bit better than glycerol for long-term effectiveness, but there's no consistent significant differences in the percutaneous procedures among the meta-analysis I just showed you. Complications occur just like with MVD. Infection, facial numbness, double vision, weakness with mastication or chewing occurs with balloon compression uniquely. And then bleeding and dysesthesias, just like MVD, infection, CSF leak, hearing loss, facial numbness, and diplopia. And then the radiosurgery and gamma knife surgery, they're the best in terms of being non-invasive, so there's no risk of bleeding, no risk of infection. Sometimes you need some sedation. There's a variable onset of delay of relief. So if you're having an acute episode, this is not a good technique to choose. And then the complications still result in facial numbness, dry eye, loss of corneal reflex, anesthesia dolorosa. If you damage the trigeminal nerve, you're going to have problems. So again, MVD, we know that it's a reproducible procedure that's very common, most commonly performed treatment for trigeminal neuralgia. But the one point I'm going to make is that when we teach residents this procedure, everyone thinks about using Teflon. And Teflon is certainly not mandatory. It holds no magical properties. This is what it looks like when you put it in surgery. This is what it looks like when it causes a problem with inflammation of the brain around it. And these are inflammatory giant cells. Go ahead and Google Teflon granuloma. Again, in patients with trigeminal neuralgia, MVD surgery is frequently the procedure of choice because it's highly effective for pain relief, treats the problem, causes no nerve damage, adds the accepted standard therapy. Now, again, one point I want to make out for patients, because we see these problems at the Medical Advisory Board and at the Facial Pain Association, that sometimes people don't always recognize these hallmarks. It's unilateral pain, sharp stabbing, electric, episodic, and acute. We frequently see pain-free intervals. Light or incidental stimulus can trigger a severe response, and even initial dental work, not causing the problem, but can trigger the severe response and the onset of TN symptoms. Pain localizes to the division of the trigeminal nerve, and the severity persists and worsens after an initial dental procedure. I want to point this out so much because so many patients that come to FPA have been to a dentist, and it's not just the first problem, the first procedure that they go through. It's when they have multiple procedures before they begin to get suspicious that it's something else besides their teeth. So entertain trigeminal neuralgia as a diagnosis before multiple dental procedures. And a second opinion is always your best action to mitigate undesirable outcomes of having multiple irreversible procedures done. Now, what about the second article I referenced? Dr. Zakrzewska talked about the treatment outcomes in trigeminal neuralgia, a systematic review. When I say systematic review for Dr. Zakrzewska's article, I'm talking significant stuff. They reviewed 467 studies of outcomes from treating trigeminal neuralgia, both surgically and medically. And if you look at their list of references, 484 references, I challenge you that anyone who looks at a scientific article, extremely rare that you'll have this many references of cases that have been reviewed. The sad story that I have to close with is that the studies that collected data on pain, which were almost all of them, and side effects, so that's good. However, few of these studies collected data on the impact of treatment on physical and emotional functioning and on patient satisfaction with the procedure that they chose. There was a high variability in outcomes measures and that were used for pain relief, as well as pain intensity and frequency of pain episodes. And again, I'm sorry to say that this is the most savvy conclusion that we can reach when we try and ascertain what's the right treatment and how do we compare right versus left or this versus that. Patients and clinicians currently have no reliable way of comparing outcomes in TN. When I say reliable, that means we can honestly say without bias and really looking at apples to apples comparison, especially if you compare medical versus surgical treatments. And she goes on to talk about when medical therapies are evaluated, they thought medical effectiveness was positive if 50% of patients are pain-free. And typically the bar is held to a much higher standard with regard to surgical outcomes. Now you can say that makes somewhat sense because the surgical outcomes, you're choosing a higher risk procedure. Medicine doesn't work. Most of the time, you just stop it if it has side effects or consequences, and you're all good. Surgery, obviously, and ablative procedures that damage create an irreversible situation. When there are complications related to that, the downside of the procedure is much more significant. So while it's understandable, it's not always apples and apples. Neither the complications are apples and apples, nor are the measurement or fairness of outcomes apples and apples. The biggest point to take home is that the variability in the reporting outcomes, as well as the lack of validation of the measurement instruments, identifies the need for the preparation of a well-defined core set of outcomes. And the reason I bring this up is the Facial Pain Association is currently underway trying to develop a database registry that perhaps we can get to some consensus as how we're going to move forward to get this information that we need. We have a more reliable way of comparing the outcomes and reliable way of knowing the risks and benefits of all of these treatments, both medical as well as surgical. Thank you very much, and hopefully we'll be able to answer some of your questions.
Thank you, Dr. Zimmerman. That was excellent. That was really a fantastic presentation. Thank you for showing those slides. We do have a ton of questions. Some of these you may have addressed in your talk, but I just want to reiterate because they do appear a couple times in the Q&A. So I'll start with what surgical options are available for people with TN who don't have a visible compression.
So one of the things that we commonly get these days is a high resolution, what we call T2 weighted MRI, typically Fiesta, KISS, or CISS, space SPC. And those are best to identify vascular contact or compression. They're not perfect. I think all the surgeons will have said we've seen cases where the MRI looks negative and we still explore. There's even some debate whether MRI is actually necessary. You should typically always explore patients that have classic TN. So if you don't have a lesion, I still think if your TN is classic, the MRI is not a perfect study, and we do see cases of other findings as well. But we can find vascular compression with a negative MRI. If the symptoms are typical enough, you can be explored. I don't think many surgeons would argue against that, but there will be some that say, no, choose a different option, that's ablation, which is reasonable because the chance of finding something clearly has a lower likelihood of success than a positive MRI.
Okay. What about patients who have autoimmune conditions such as Sjogren's or scleroderma that have caused the TN? Should they consider surgical or ablative treatments?
So that's a great question. You know, the most common patient that has a medical condition, if you will, that has trigeminal neuralgia is multiple sclerosis, an autoimmune condition. And in that case, specifically the insulation around the nerves in the brain, the central nervous system insulation, is attacked by the body. Yet we still see in patients like that, they have vascular compression and they can respond to microvascular decompression. However, if you have that symptom and you don't have clear evidence of vascular decompression, it may be very logical to pursue the other options, either the percutaneous procedures or radiosurgery. In that case, we don't always have an option other than a palliative or an ablative procedure. But they should still look for vascular compression because I suspect all of our surgeons in the MAB have seen patients with MS that have had vascular compression. And they do respond to microvascular decompression.
Okay. We have many people attending this talk today who have had multiple different procedures done. So this particular one says, I've had a rhizotomy and gamma knife and that didn't help the atypical TN and did cause anesthesia dolorosa. Is there another surgical option? And in this particular case, the MRI does not show the compression.
Now we're stuck because once you go down the pathway of anesthesia dolorosa, what that means is that the nerve has been injured, typically by an intervention. So either a surgeon or radiosurgery or a rhizotomy. And unfortunately, now you're going down the path where the nerve that has only been injured, but it's begun to heal abnormally. We know that we can do certain rhizotomies of any type, damage the nerve, and it heals in a way that doesn't produce the symptoms of burning, crawling, pulling, tightness, or chronic pain syndrome. When the nerve begins to heal abnormally like that, now we're stuck with a problem that really needs to be addressed carefully because you have to avoid more damage, which causes more abnormal healing. So my personal preference is once you have anesthesia dolorosa, I do not recommend any more ablative procedures. And if you don't have typical components of TN and vascular compression, I would not recommend the second MVD. If you have components that are typical, shocking attacks of pain, your typical TN pain, against a background of anesthesia dolorosa, chronic burning, pulling pain, you can still help patients if they have evidence of vascular compression. So let's say anesthesia dolorosa after gamma knife, and they still have a vessel loop and it's still causing obvious compression. You can still help them with vascular decompression if you don't injure the nerve anymore. But you have to be very careful, and you have to have typical symptoms. Atypical facial pain, that's a longer discussion of what that really means.
Okay. This question may fall right into that same category, but I'm going to go ahead and ask it anyway. This patient has a compression visible, but symptoms are supraorbital neuralgia and hemifacial spasm. Does that warrant a decompression on the trigeminal nerve in addition to the facial nerve?
It warrants a better history. So, with trigeminal neuralgia, one of the things I didn't talk about is the difficulty we have with the diagnosis. There is no test that gives us a defined diagnosis that this is TN. Now, there are some criteria that will say, yes, it's into a diagnostic category of TN. However, it's not like a definitive answer all the time. And when you have this discussion of, well, I have supraorbital neuralgia, or a very focal concept of trigeminal neuralgia, either tongue pain, nose pain, upper lip pain, only tooth pain, one tooth, it's just one tooth, it's right here. When those patients come to you, they can still have typical TN. So it's really hard, and you have to take a good history, because if the doctor, the physician, either be neurologist, surgeon, other pain professional, oral surgeon professional, if they don't listen to the patient's history, they will not be able to make a good decision about whether this sounds like it's something that I can treat. From the surgeon's perspective, it's all about the history. It's all about listening to the patient. And you have to know that their story is. They have to understand what that character of pain is. And part of that is the experience of the surgeon. You've heard enough of these stories, you've heard enough of symptoms like this, that you have some experience that this can or cannot be helped. So unfortunately, it's, again, more talking to the patient, a better history of what exactly your components are of this. Now, the component of hemifacial spasm in conjunction with this, that can occur. That's an entity called tic convulsif, where you have both trigeminal neuralgia and hemifacial spasm. That can be treated with microvascular decompression, so there is an option there as well. But again, it's part of the history taking, physical exam. It really is to make the correct diagnosis before you go and decide on a surgical procedure.
Okay, great. Would you do an MVD for a vein as opposed to an artery pressing on the trigeminal nerve?
Absolutely. Vascular compression by veins are well known to be a little bit more common in my experience to cause trigeminal neuralgia type 2, so to speak, where you have some abnormal feeling of the trigeminal nerve in between your typical attacks. But definitely, if you see venous compression, we see it a lot. It's not unusual at all. And yes, that does warrant an MVD type procedure. A little different approach, but yes.
This question I've seen pop up in a couple of different sessions that we've had last night and today, and that is, can you have an MRI despite a Teflon sheath from the MVD?
I'm sorry, can you have a Teflon?
Can you have an MRI despite having the Teflon?
Correct, yeah. So Teflon itself, it was, assuming that there was nothing else placed in the brain that contraindicates an MRI. So no metal plate that's not MRI compatible. Most commonly, we use titanium plates when that is placed. But Teflon itself does not contraindicate at all an MRI.
Okay, excellent. Is rhizotomy or ablation useful for non-lancinating TN pain? And why would you use one type over the other?
Great question. But again, non-lancinating TN pain, it's another discussion with the patient. It's a longer history-taking session. It's time spent listening to, what do you mean when you tell me about your pain? And again, there's so many other types of problems, like, is this post-herpetic neuralgia? Do you happen to have MS signs or symptoms on your MRI? Did you have facial nerve injury at some point? So, trigeminal nerve injury from trauma in the past. So you really need to take, and non-lancinating TN pain, I need to explore that a little further. I can't just use that as a starting point. So much of trigeminal neuralgia care involves listening to the patient, hearing their story, and trying to really get a handle on what was it like before your first drugs. What was it like before your gamma knife, before your first MVD, before your first balloon compression? All those are very important. It's the journey that the patient goes through. But really, if you can go back to the beginnings, that helps sometimes.
Okay. We have a couple questions about recovery of, I think, probably ablative procedures after an internal neurolysis. Will the nerve ever heal? And a second question about facial pain caused by damage from septoplasty. Can that damage be recovered by treatment?
Okay, so let's go back up and do the first question today. The injury to the nerve and recovery. What was that first question, Melissa?
About the internal neurolysis.
Internal neurolysis. So I have a personal perspective. Internal neurolysis. You know, when they add that to the MVD, that's not part of the decompression. Internal neurolysis, or combing or stroking the nerve, typically is done either by a blunt hook or a sharp knife, very fine, but it's tried to separate the fibers of the nerve apart. And invariably, that will cause some degree of injury. So in some sense, that's a partial rhizotomy. It's not directly cutting the nerves intentionally. And you kind of stroke the nerve parallel to the fibers or separate the nerve parallel to its fibers. But, you know, the nerve is not like a perfectly straight wire or perfectly straight cable. When you do any of those procedures, you are injuring some of those nerve fibers. So it really becomes a rhizotomy. And while some nerves that haven't been permanently injured can recover, there are sometimes, as we all know, that when something becomes numb, it may never recover. So the recovery is a little bit hard to predict. One of the things we do know about injury is that the injury is proportional, or the rate of relief of TN pain is proportional to the amount of injury that occurs. So the greater the rhizotomy, the reason balloon compression and the reason radiofrequency rhizotomy happen to have a greater degree of initial effectiveness, let's say the glycerol injection, is because they do a greater degree of damage. And that's why the greater degree of numbness, greater degree of, in the case of balloon compression, you get jaw weakness from involvement of the motor branches of the trigeminal nerve, and diplopia from compression of the other adjacent branches of the cranial nerves. The degree of injury is proportional to the relief. The problem is that also proportional to the amount of numbness you have, the potential for dysesthesias or annoying pain, or the development of anesthesia dolorosa. So I think all of us would follow the rule of thumb: the least amount of damage is the best, no damage is the best.
Excellent. Okay. Is there any research that you're aware of that shows that if you have an MVD surgery done in early stages of diagnosis, that you can have a better outcome?
Yeah, again, I think that some of us who seen many years of patients would tend to believe this. I haven't seen any strong data that's been collected to show that patients early do better than late in terms of treatment and the duration of TN. If you follow what we best understand the cause of TN to be, in terms of loss of myelin due to vascular contact or compression, and then the potential healing that occurs where patients' nerves try and reconstitute the myelin. If they do so in clumps or abnormally, and you develop a lot of what's called pathological remyelination, aberrant remyelination, where it encompasses a clump of nerves as opposed to single nerves, then it may be that that's why some patients, A, may never get better from their procedure no matter what they have, because they have this abnormal remyelination. So I think that early on, treatment that would get rid of the vascular compression would stop more damage and would stop more reaberrant or aberrant remyelination.
Okay. And we are just about at the end of our time today. So I know this might be our last question. And the question is, why don't most surgeons choose vascular repositioning as opposed to using Teflon cushions? And I know that I just wanted to see your thoughts on that.
So, you know, through the FPA, I've been involved with for many years now, and I've always been championing the cause of why put something foreign into someone's head if you don't need to. I happen to use glue. There are articles written about slings and clips that are inert and that hold the vessel away from the nerve, so you leave nothing touching the nerve. I think that, you know, Ginetta was a great innovator. He was a great statesman for trigeminal neuralgia, because everybody in the world learned more about TN because of Dr. Ginetta. And he used what he had at the time, the surgical techniques he had, the microsurgical techniques, the lighting in his microscope, as well as what could I use? Let me think, what could I use? Let's see, Teflon seems inert, although we know that Teflon is not inert. If you go through the oral surgery literature about Teflon implants for TMJ replacement, Teflon causes bone erosion, it causes soft tissue damage, and it causes granuloma formation. So we know that, if Teflon was good, that's nice. But if it's better without something foreign inserted, that's why my preference is, and there are many other surgeons who have written articles about non-compressive decompression. In other words, nothing's against the nerve. So there are doctors in Germany and doctors France, and I think even a large number of doctors in Japan surgically will not put Teflon in anymore. They try and do the operation by repositioning without using something that actually touches the nerve. If you can use Teflon and put it so it doesn't touch the nerve, that obviously is a more reasonable approach, but so many times you see Teflon in contact with the nerve. It's rare we see Teflon placed that holds the vessel away and that doesn't involve contact with the nerve. Teflon and the nerve together, in my perspective, is something that can be avoided and therefore should be avoided. Even if it's a small number of complications, recurrences, or failures, why not reduce that small amount of possible adverse events or adverse outcomes?
Excellent. And I know there's a lot of opinions, particularly on that issue. So we do have a surgical Q&A coming up later today where many surgeons are going to, a couple different surgeons from our MAB and our board of directors are going to discuss this issue. So Thank you so much, Dr. Zimmerman. This was an excellent talk, and we really appreciate you answering all of our questions. We are getting ready to move into Dr. Linsky's presentation on repeat MBDs in just a few minutes. So if, as attendees, if you want to navigate back to your agendas to find your next session, you are welcome to do that. Again, thank you, Dr. Zimmerman, very much.
Thank you all. Have a great day.